Okay, great. All right, we'll start. Thanks everybody for joining us, and thanks especially to the speaker, Gaurav Chattree. He is a movement disorder specialist who did his fellowship work at Stanford and has stayed on, and we're so glad to have him giving his annual update about what's going on in Parkinson's disease treatment and what's happening in the pipeline in terms of therapeutics. So take it away, Gaurav.
Great. Thank you, Robin. And thanks everyone for having me today. So as Robin mentioned, I'm going to be talking about the latest updates in therapeutics for Parkinson's disease. My last talk was around mid of last year, so it's been a little bit over a year since we last met. I just want to start with a brief disclaimer. I was involved in the adaptive deep brain stimulation study at Stanford, which I talk about briefly at the end. But other than that, I'm not involved in any of the ongoing trials. I don't formally endorse any of the trials or treatments, but my goal is to educate you on the latest treatments for PD. So I think before we jump into the treatments, it's helpful to think about two classes of therapies for Parkinson's disease. So therapy group one are called disease-modifying therapies. So these are treatments that would slow or halt the underlying disease progression in Parkinson's disease. So they would do that through preventing progression of neuron dysfunction or neuron death. So therapies that prevent further neurons from being impacted by the disease. So unfortunately, we don't have any approved disease-modifying drugs currently for Parkinson's disease. I'm going to talk about a lot of drugs that are in the pipeline for this. Um, I'll just put in a plug. The only thing we think may slow down disease is exercise. So exercise should be thought of as a treatment for Parkinson's disease, 30 minutes, 3 times a week at least, doing some sort of physical activity that gets your heart rate up, gets your breathing rate up, and it feels like a workout. The other group of therapies are symptomatic therapies. So these are therapies like levodopa. They improve or restore function for patients with Parkinson's disease by acting on some pathway. For example, levodopa in Parkinson's dopamine levels are low, so you take levodopa to boost those deep dopamine levels, and then once the medication wears off, the dopamine level goes low again. So it doesn't prevent the underlying progression of the disease, but it does help improve symptoms, quality of life, and restore function. So I'll be splitting the talk into these two categories as I talk about approaches today. So I'll start with disease modifying approaches. This is just a list of some of the things I'm going to be talking about. So the first group of therapies I want to touch on are those that target a protein called alpha-synuclein. So one of the major hypotheses for Parkinson's disease and how Parkinson's disease starts and spreads is that there's this protein called alpha-synuclein. Everyone has it in their brain. It's involved in normal brain function. And something causes that protein to become misfolded. It enters some shape that it's not supposed to be in. And then once it enters that shape, it can cause other alpha-synuclein nearby to also get into that misfolded shape, and then they can clump together. Those clumps can then spread throughout the brain and cause inflammation and toxicity and neuron death, resulting in Parkinson's disease. So based on that theory, a major goal would be to stop alpha-synuclein misfolding and or stop it from propagating or stop its toxicity. And so there's many strategies that have been thought up over the years and things that are being worked on. Some ideas are you passively inject an antibody into the bloodstream or the brain that targets alpha-synuclein clumps, or you have the body generate its own antibodies to alpha-synuclein, so this would be like a vaccine. You could have a small molecule that goes in and interferes with alpha-synuclein clumping, or something that breaks down alpha-synuclein after it's misfolded. So all of these strategies, are being worked on in some, stage or another. I'm going to focus on a few that are farthest along. So the one that is the most farthest along is this medication called prasinezumab. This is an antibody against alpha-synuclein. So it goes in and it binds to alpha-synuclein clumps. Then when it binds to those clumps, it can lead to those clumps being broken down and taken up, destroyed, reducing alpha-synuclein clumping in the brain. So initially, there was a big study that was published in 2022 that looked at this drug in patients with early Parkinson's disease, and it had to be pretty early. You weren't allowed to be on dopamine medications at the start of the trial. And unfortunately, their overall outcome they were looking at that time was negative. But they looked at some of their digital markers, their wearable markers, people wearing tremor devices or speed of movement devices, and they were seeing some positive signal in patients that were getting the drug. And then if you look over on the graph to the right, let me see if I can get my laser pointer here. Yeah, so if you look at this graph on the right, gray is historical controls of patients with Parkinson's disease. So this is a line showing disease progression in patients with Parkinson's disease from prior studies that patients that weren't getting any treatments, how does their disease progress over time? So there's a score on the y-axis and years on the x-axis. So, and just to clarify this, these patients in the gray line were not part of this study. These are measurements and recordings done outside of the study, done in prior groups, this PPMI group through, I think, the Michael J. Fox Foundation, where they were just studying patients' progression. And so you can see, as we think of in Parkinson's disease, there's this progression of disease over the years. In blue are patients that received prasinezumab. And so that is either they got it right away or there was some delayed start to treatment. And at the 1 year mark, it's hard to see a difference. But they kept the trial going. And at the 2 year mark, there's minimal difference. And so it wasn't statistically significant. But they let patients keep taking the drug even after the study ended. So this is called the open label extension. So by year 3 and year 4, they started to notice, well, these patients, aren't really progressing as we may have expected them to. So maybe this drug is doing something to slow down the progression. Now, there is always a caveat in these type of studies that, the patients that were not in this study are a different set of patients. They have different features and they may have different progression rates. And the patients that are in the study, there's something about them independent of the drug where they would have had slower disease progression. Maybe they exercise more or, do other things to manage their symptoms better. So that part is there, and it does make it a little complicated, but it was enough that the company felt like, let's continue researching this drug. So then there was another trial called the PADOVA trial, early Parkinson's disease. You could be on dopamine medications. And again, it didn't technically meet its, overall outcome that it was looking for, but it did show a lot of positive signals with trends towards slower progression. There was a subgroup of patients that were on a stable dose of levodopa. They showed less progression with the drug versus without the drug. So taking this together, the company has decided to move to a phase 3 trial. So this will include a lot more patients. It will be statistically strong, and it will be designed to really be definitive, to definitively answer the question, is this drug helpful for slowing down Parkinson's disease? So this trial is in the initial phases. It's starting up, and we do hope to have this trial at Stanford. UCSF will almost certainly have this trial. So I think everyone should be potentially looking out for this. This drug, it's been studied in a lot of patients now, and it does not really seem to have any major adverse effects. Nothing really major that stood out. So, this trial is one that I'm most excited about, one that I'm really following closely, and really hoping that things work out here. And so we'll know in a few years. So it'll probably start, I'm thinking maybe next year, and then after a few years, we'll start getting the results. So I want to just talk about some other drugs that are also going after alpha-synuclein. These are different companies, different groups. So there's another one, ABL 301. You'll see throughout this talk, there's a bunch of these code names. Certainly they're hard to remember, but I just want to talk about, what they do, how they work. And so there is an antibody, again, against alpha-synuclein, just like prasinezumab. But the difference here is that it goes into the brain better. And the company's calling it like this Trojan horse mechanism, meaning it goes to some receptor in the brain, it presents itself as something else that the brain would normally take up naturally, but in reality, it has the antibody against alpha-synuclein. So it's sort of Trojan horse, it sort of tricks the brain into taking it up so then it can act against the alpha-synuclein potentially better. So phase one study was completed, showing it was safe and tolerated. Usually phase one, just a little bit about, because we're going to be talking about phases, I should have given a little introduction there. So phase one is usually just to see if a drug is safe and well tolerated. They may test it in patients with PD or patients without PD. It could be normal patients. Phase two, you're starting to look for signs of potential efficacy, but again, a lot of it is looking at safety and some initial biomarkers. Is it showing some trends of things that you would expect? And then phase three is typically the definitive study where it's on a larger group of patients, and that is what the FDA may use for deciding on approval and how clinicians decide, okay, yes, this drug actually does look beneficial. So they completed phase one. They're planning for phase two. And I believe Robin will send out my slides. I'll convert them to a PDF form. But they have a YouTube video showing how this drug works. And it is they must have gotten some really good graphic designers for this. It really shows you in high detail how this drug gets into the brain. It's good for just understanding what alpha-synuclein clumps may look like, how they may be spread out against neurons. I think it gives a really good picture of the underlying process in Parkinson's disease. It's a very well-made video. Um, and then another approach is a vaccine against alpha-synuclein. So like a vaccine, just like any other vaccine, it causes your body to start generating antibodies against alpha-synuclein. So your own natural antibodies rather than giving you antibodies through an injection. Your body makes its own. And so they did a phase two trial. They're calling it Vaccine play on vaccine. It had positive interim data with signs of clear antibody formation. So patients were making clear antibodies against alpha-synuclein, and it seemed well tolerated without safety issues. We just have some interim data here. We don't really have the full results, so we're waiting on those, and then we'll see, does this drug move on to phase three. Oh, and I should say, if anyone has any questions, feel free to, put them in the chat as I go along. And Robin, feel free to, pause me and I can pause and answer questions. All right, so now moving on to a different type of drug. So this is Ambroxol. You may have heard about this. This has been in discussion for a few years now. It is a cough syrup used in some countries for many years to break up phlegm. It's not approved in the United States, not because it's dangerous or anything. It's more that, sometimes drugs just don't get approved here if the company thinks, oh, there's not really a market for it. There's not really room for us to make profits. USA already has other drugs that do this. So there's no major signs that this is a dangerous drug. It's just not approved in the United States for logistical reasons. And so one thing that researchers found is that Ambroxol may help the brain with clearing up waste products a bit better. So to go into that a little bit more, there's this protein called glucocerebrosidase. It is a protein that helps brain cells clean up waste they no longer need. Mutations in this gene, in this protein, are associated with an increased risk of Parkinson's disease. And Ambroxol appears to increase the activity of this protein, allowing cells to clean up the waste better, which may protect the brain cells. It was a very small trial in 2020 with 17 patients. It showed some, safety feature signs of safety. It shows that they were able to get to their target of glucocerebrosidase. But now it's time for the phase 3 study. And there were some delays, but it has officially started now. I believe the first patient has already been dosed. So there's 330 patients total. They're going to take it for 2 years and they'll be tracking, quality of life and movement ability. Um, you will notice they're only at doing it up to 2 years. So that's just one tricky thing with Parkinson's disease studies in general. As you can see at the 2 year mark, sometimes it can just be hard to tell if there's really been a difference with the drug or not. You can see this, with prasinezumab. So that's, just one caveat with these studies. And part of it is these studies cost a lot of money. They take a lot of time and effort. So it can just be hard to go past 2 years. Also, people are waiting for results, but I'm sure they'll do an open label, extension if things look positive there. One comment is, yeah, I don't recommend you just going out and buying Ambroxol. In these trials, it was a very high dose of Ambroxol, and so we're a little bit less familiar with, what this effect might be of this high dose. So please don't go out and, buy your own Ambroxol um, to to start taking it. Again, the trial was very small, just 17 patients. We'll know a lot more after the phase 3 study. Okay, moving on to another class of medications. These are called LRRK2 inhibitors. So to give a little bit of background, we know that certain mutations in the gene LRRK2 contribute to the development of PD. So certain patients who have these mutations, they're more likely to get PD. Those patients that have this mutation, we see that the enzyme that is coded for by LRRK2 is hyperactive. It's too active. It's doing too much of its job. And so the idea is that maybe this hyperactivity is somehow leading to PD. So if that's true, then the goal would be to design a way to slow down this enzyme. So that's why these are LRRK2 inhibitors. But there's a variety of strategies, many different strategies, genetic approaches, small molecules to bind to the enzyme. So various approaches. I'm just going to focus on two that are the farthest along. So there's one small molecule, LRRK2 inhibitor, BIIB122. This is by Denali Therapeutics and Biogen. A phase 2b study is underway now as we speak. And this is both in patients with and without the LRRK2 mutations, because there is a thought that maybe even those people who don't have the mutation, the LRRK2 could still be hyperactive and contributing in some way. Still enrolling at UCSF so if you have a confirmed LRRK2 mutation, you may want to look into this clinical trial going on at UCSF for this drug. This is an early study, so again, it's hard to say whether this drug will be effective or not, but it's something to consider. You can always just ask them about it. And then there is another drug by another company, again, trying to slow down LRRK2, NU411. And their approach is a little bit different. They will send you a saliva test and they will look to see, do you have evidence of LRRK2 overactivity? I don't know exactly what test, that may be their own proprietary test, I'm not sure. But they have some sort of test to see whether you have this hyperactivity. And if you do, then you can be enrolled in their trial. And so the trial is just in the process of starting up. If you go to the link for this drug, you will see there are some California locations. So you can look to see if there are any close to you that you may be interested in. All right, now I'm moving on to, again, a different class. So as you can see, I'm talking about all these different approaches to try and slow down the progression of Parkinson's disease. So there's many different ways people are going after this. This one is targeting neuroinflammation, this one and the next one. And so again, background here is that you could imagine that if once the alpha-synuclein may be clumped, it could lead to inflammation in a couple ways. One, it could be that the clumps themselves, they are abnormal. They could be treated as something foreign by the body, and so there could be some inflammation surrounding that. And if those clumps are toxic, then if neurons are undergoing some toxic process, maybe they're degenerating, that can lead to release of some compounds to suggest distress. Again, that would also raise inflammation. And then if there's inflammation, that causes its own issues. Again, it can be toxic, damaging to the brain. And so the idea behind this class of drugs is to try and reduce neural inflammation to slow down the progression of the disease. This is by Biohaven, and it binds to a couple proteins there. And they did a phase 1 trial, again, showing it was safe, well tolerated. It met some of their markers that they were looking for. And so it seemed to be reducing biomarkers of inflammation. And so they are going to be starting up a phase 2/3 clinical trial to evaluate effectiveness and safety. It will be relatively large, 550 individuals, early stage Parkinson's disease diagnosed within the last couple of years. There is a caveat with this study, I believe, that I think you cannot be on any medications, including levodopa, for a certain amount of time before you start this study. And I think that's just to help them really understand whether this drug is having an effect without some confusion about whether the levodopa that you're on is affecting you in any way. And the primary goal is to determine if it can slow functional decline. And we're looking to see if this will be at Stanford. It may be at other California sites. So this is also one that we'll know more about soon. Another approach targeting neuroinflammation, different protein here. They had a small study that showed some positive signals, and then they're going to do another smaller study, maybe just 30 people, and we'll know more by the end of 2025 or early 2026. But again, same sort of idea, trying to reduce inflammation in the brain that may be going on with Parkinson's disease. This is a totally different approach. It's some other enzyme, c-Abl kinase, which the company believes there's evidence showing it contributes to the disease. They're trying to protect dopamine-producing nerve cells from damage. And they did a phase 2 study. We don't have the full results yet, I don't believe. As early as yesterday, I think they were still releasing some information. But what they are releasing seems to be positive, so they'll likely be moving towards phase 3. This is not a compound that you would take by mouth or be injected with into the bloodstream, but something that is injected directly into your brain. So let me give a little bit of background. So it's a gene therapy approach. So scientists in general, we've learned to use some things that are present naturally in the world. So in this case, viruses, and change them in some way to use them to our advantage. So viruses typically infect cells and then they'll spread from cell to cell. But what is done in this case is a virus is changed in such a way that it will only infect the cells that we inject the virus a virus to. So let's say we inject this into a certain part of the brain. Only the cells nearby that injection site will get infected by this virus. And when it gets infected by the virus, it won't be toxic or lead to the typical things we think about with viruses, inflammation, but instead it will deliver a gene that we want it to. So we've basically hijacked viruses to do what we want them to. We're having them deliver a gene that may cause the neurons to be protected or restored from damage that may be going on in Parkinson's disease. So it's a very different approach than some of the other things that I talked about. Gene therapy, the idea of using viruses to our advantage to help with diseases, has already been approved in humans. So there is a condition called spinal muscular atrophy in children at a very young age. If you inject them with a very similar virus and we can get their neurons to express something that we want, it leads to big time improvement in those patients. So gene therapy has actually already been approved in human. I think it's like 5, 6 years now, and even more and more are being created. So this is one for Parkinson's disease. This type of approach, unfortunately, it's had some negative results in the past, but it's still moving along because I think the company and groups involved feel like they've made some improvements in how the injection is done, how the targeting is done. Maybe they've done some improvements to the virus itself. I'm not sure. Don't quote me on that, but I think that may be going on. So this trial is underway now, a phase 2 trial, Regenerate PD. It's double-blind sham surgery, so everyone will get the injection, but some people will get the virus. Some people will not get the virus. They'll get maybe like, a saline solution or the same solution, but there'll be no virus in there. And so that's a way to have two groups and see if one group benefits from the virus injection or not. But it will be blinded. It will be a placebo arm. So it's more statistically robust. And so it is currently enrolling approximately 87 patients. It's going on at UCSF. And so I've put the link here. And yes, you'll be followed for 18 months after the procedure. It is a brain surgery. So you will have to undergo a brain surgery where they do a injection into the brain. So last year when I gave my talk, there were a few drugs that I mentioned that I don't have slides on this year, and we have some data in them, so I want to give some updates. So one was exenatide. It's a GLP-1 drug, just like Ozempic or Wegovy or Mounjaro, some of those things that you've heard about for weight loss or diabetes. And we were looking to see would it be beneficial for Parkinson's disease. And there were a variety of smaller studies that did show positive signal. And then there was a much larger study that was done in the UK, a phase 3 trial, and unfortunately, it did not show benefit. So that was very disappointing. We were all disappointed when those results came out. There may be a few ongoing trials still with this class of drugs, but unfortunately, I would say, the study had a lot of patients. I think it was well done. It may be unlikely that this class of drugs will be helpful in slowing down PD. So that was, certainly a big disappointment. Another drug was called Butanitap that I had talked about. And this, the situation's a little unclear. It finished its phase 3 trial, and the company released some information. I don't think they published any studies, but the company basically released some statements, and they phrased it like, yes, we saw some positive signals in these groups and endpoints, but they didn't comment on some of the major endpoints, their major goals. If you look at some sources like the Parkinson's Disease Foundation, their website says the study did not meet its primary goal. So I think that unfortunately may be the case. If you go to the company's website, they seem to be now focusing on Alzheimer's disease, less so with Parkinson's disease. So I'm not exactly sure what is going on with this drug, but we'll see if the company releases more statements. I will say there was always a reason to be a little bit skeptical about this drug. Their phase 2 study was relatively small. But yeah, we'll see. We'll see once maybe they'll release their full data and results. Okay, I'm going to pause there. So that was about disease-modifying therapies. I just want to see if anyone has any questions before I move on to the class of symptomatic therapies.
If you have any questions, just put them into the chat or the Q&A box. For sure the chat should work and Q&A should work too. Back on the cough medicine one,
Yes.
Ambroxol, I see your note about it's a high dose. Don't do this on your own.
Yeah.
I think that's a good warning.
Yeah.
Um, and so the phase 3 study will take 2 years, you said,
Hmm.
in the
Yeah.
United Kingdom.
Yeah. And it just started very
Just
recently.
started. Okay, that
Just
was my question. Okay, just started.
Yeah,
Okay.
they had some delays.
All
Um,
right. Um,
okay, looks like there's no questions right
oh,
now.
there's one
Oh, oh,
question.
okay.
Let's see. In the Q&A box, let's see. How about diet and nutrition to reduce inflammation? Is that effective?
I think it's one of those things that's still being studied, and it's hard to say. There are these anti-inflammatory diets that it wouldn't hurt to try them, I think. There are a lot of patients that are trying them. The tricky part is that neuroinflammation is really complicated. There's many different proteins involved. You can see type 2, JAK1, NLRP3, and these are just three out of probably hundreds. And what is hard to say is when you do an anti-inflammatory diet, are you affecting the key players involved in Parkinson's related neuroinflammation? And I think that really remains to be seen. And I do think people will be studying this to see if it helps with that, but I don't think we know that yet.
Yeah, I would think a diet nutrition study would be very hard to do. Um, One of the things that I don't know if you saw Dr. Oken doing grand rounds. I think that was maybe last Friday.
I
Um,
saw part of it. Yeah.
so his hypothesis, along with Ray Dorsey, is that TCE and paraquat, so chemicals in the water and in the air
Hmm.
and in our food, are causing the great increase in Parkinson's disease. And it's his belief that if we can, if we immediately, anybody with PD immediately stops taking in these pesticides and chemicals, that they, based upon two very small studies, I think one was in Rotterdam and one was somewhere in the United Kingdom, that rates of PD will come down, and uh, that A, and B, uh, people can see symptomatic relief from this decline in pesticides and
Hmm.
other chemicals. Is there anybody researching that as a a disease modification, disease modifying therapy?
Hmm. I'm not sure if anyone's studying that exactly. I think there are studies, some of the compounds you've mentioned that pretty strongly link those compounds to PD. And so
Right.
there's certainly a push to reduce those compounds in our environment, in our food, at the policy level, at the regulatory level. In terms of using that to create some new, I guess, therapeutic strategies, I'm not familiar with if anyone's doing that. They may be using it maybe in animal models, those compounds, to then see if there's a way to block the response that could happen from those compounds. I think
Right.
some groups are likely doing that. Like if you inject paraquat, I'm not 100% sure, but I'm thinking maybe they'll do a study like if you inject paraquat and it starts to lead to, PD-like signs, is there
Yeah.
something we could do in that case to stop paraquat from doing that? Could we give some sort of like antidote per se?
Right. Yeah.
And so I'm sure there's studies at the animal level.
Right. Okay. We have a couple more questions in the in the chat. A more general question: how do you go about joining any of these studies, or finding out if you're even the kind of patient they're looking for? Are they mostly for younger patients in early stages, or do they sometimes involve those over 80?
Yeah, it's a good question. I think the way things that I do to keep up with these trials, so both UCSF and Stanford, we have like a list of clinical trials, and um, on the website, it will often have eligibility criteria. So it will discuss, what are the things that they're looking for, age, years of disease, medications that you're on, things like that. So you can look at these eligibility criteria. Um, clinicaltrials.gov, that's a database of all the clinical trials going on in Parkinson's disease. And that's worldwide, but you can filter it by location and whether it's actively recruiting. And then I would say a lot of the major PD organizations like APDA, Parkinson's Disease Foundation, Michael J. Fox, they often have a list of clinical trials. And then I follow, I think it's Parkinson's News Today, and then there's another one called Science of Parkinson's. So both of those also have updates on new trials going on for Parkinson's disease. I will say most trials, yes, are looking for patients typically earlier in the disease, but there are some seeking out patients at the moderate stage or sometimes later stage. Above the age of 80, it's less common, but I think it's possible. I'm not 100% sure on that, but yeah, it just depends on the individual trial.
Yeah, hats off to any of those out there over age 80 and doing great,
Yeah,
participating in the
yeah,
webinar.
for
Awesome.
sure.
Okay, another question is, are these drugs being studied also in Lewy body dementia? Maybe you could just talk about alpha-synuclein and
Yeah.
Lewy body and multiple system.
Yeah, so one of the ideas is that Parkinson's disease and Lewy body dementia, it's the same underlying process that alpha-synuclein is building up and clumping and is toxic. It's what's different is where in the brain it may start and how it may spread, what areas that of the brain are affected. So in Lewy body dementia, it's more cognitive areas of the brain that are affected, whereas in Parkinson's disease, it's more of the motor. But there's a lot of overlap between the two diseases as the conditions progress. And so I would say a lot of treatments here are not being directly studied on Lewy body dementia, but I feel that they're likely to be helpful if they end up being positive in PD. There's a good chance they'll be helpful in Lewy body dementia as well.
Okay, great. And how about multiple system atrophy?
Multiple system atrophy is a little bit more challenging. It is still alpha-synuclein, but the way it affects the brain, what cells in the brain it affects are different. So I'm not as confident that the treatments, if they're effective here, will be effective for MSA, but they may be. They may be
Okay,
because there are some shared similarities. Yeah.
okay, great. Thank you.
Okay. All right. So moving on to symptomatic therapies. So these are medications that you take to help with your symptoms. So you may take them on a daily basis, or use them regularly in terms of medications, or there's some other approaches that I'll talk about that are like surgeries or stem cell injections or infusions. So the one that is closest to being potentially approved. The company has submitted a new drug application as of last month. This is a once a day oral pill that acts against certain dopamine. I shouldn't say against, I mean, in a unique way on certain dopamine receptors. And the mechanisms is designed to improve motor symptoms while trying to avoid certain side effects that come with other dopamine drugs, like impulse control or sleepiness. And so they had a phase 3 trial that showed positive results. And so a decision for whether this drug will be approved is hoped for next year. So it'd be great to have another tool in our toolbox for helping with symptoms, because a lot of these drugs, they affect every patient differently. It can be hard to predict. Some patients are a lot more sensitive to side effects from one drug, and they don't get side effects from another drug, and other patients are the opposite. So the more tools we have like this, which have different approaches, it will be helpful to make sure that we can get all of our patients some symptomatic benefit. So I'm looking forward to this drug. Another drug that is entering phase 3 is Solenjapras. It is acting in similar areas of the brain, basal ganglia or striatum. These are areas of the brain involved in PD, and it aims to rebalance the motor circuits there. But it's a different receptor. It's not directly on the dopamine receptor. And so again, this may be a way to help with functional impairments and symptoms with less side effects than current treatments. There was a phase 2 clinical trial which showed it was helpful when it was combined with levodopa. Alone, it was a little less clear how beneficial it was. It helped with some things, but not with everything. So we'll learn a lot more with the phase 3 trial, and we'll learn these results by 2026. So dyskinesias are a side effect, or there's something that arise with as Parkinson's disease progresses and you need a certain dose of levodopa. Unfortunately, that levodopa, which is helping with your movements, can also cause involuntary movements. So those are writhing movements that you may see, Michael J. Fox having, and these are called dyskinesias. And we don't have very many treatments for dyskinesias. There is a drug called amantadine, but amantadine has side effects, it has issues. So this is a new drug that is again acting on a different receptor, but in the same area of the brain, the striatum, the basal ganglia, to help reduce dyskinesias. And the phase 2 study was positive, so it's very likely they'll be moving to phase 3. So again, this would be great to have in our toolbox to help reduce dyskinesias. This will allow us to use levodopa potentially at higher doses or use it for longer. So again, this would be really great if this drug ends up working out and is positive in phase 3. Then you may have heard about these subcutaneous infusions for Parkinson's disease. So there were 2 approved this year. One is called Vilev, one is called Onapgo. Vilev is more like carbidopa-levodopa, so it's just a slightly different version of carbidopa-levodopa. Onapgo is a different compound that acts on dopamine receptors, and both of them have had phase 3 trials showing benefit. And so they have both been approved by the FDA. And the way they work is you wear a pump, so you can wear it along your waist like that. And then it is connected via this tube to a patch that is sitting in your skin. And it's continuously infusing these compounds. And the idea of these, why would you want this subcutaneous infusion or continuous infusion, is that it could give you more control throughout the day by giving you an even amount of medication so that there's less highs and lows. This can help with reducing off time periods or dyskinesias. And so we are starting to primarily use Vilev in our clinic now, and we've had many patients with good responses. We're not using Onapgo as much. That's because I would say we're less familiar with this drug, apomorphine. It's been reported to have more side effects, but that is an option for certain patients. Okay, now moving away from medications, and I'm going to discuss other symptomatic interventions. So one of the interventions is called focus ultrasound. And the way that this works is that we think that there are certain parts of the brain, thalamus, parts of the basal ganglia, that are contributing to the Parkinson's motor impairment. So the slowed movements, the stiffness, the tremor, and that actually if you lesion or destroy that part of the brain, you can get rid of those symptoms without a significant loss of function. Like you don't actually need that particular area for your regular function. And really what it's doing is just causing issues in Parkinson's disease. And so this is an approach where they give high energy ultrasound waves. They all meet at a certain point within the brain. It heats up that brain tissue, and then that brain tissue gets destroyed or ablated. We use that term. And so there's many different targets that have been examined. Thalamus for tremor, another for dyskinesias, and then there's new targets being explored. So this is a potential option for improving symptoms in Parkinson's disease. It's an alternative to deep brain stimulation. At the end of the day, they're trying to do similar things. The targets are often similar. They're trying to also reduce, it's also trying to reduce the motor symptoms. There's pros and cons. The advantage to focus ultrasound is that once you're done with the procedure, you don't have implants that you have in your body, and the hope is that this will just continue to last. Whereas deep brain stimulation, you will have the electrodes, you'll have the battery implant, but the disadvantage is that, once it's done, there's two things that could happen. One, it could affect more parts of the brain than intended, which could cause some side effects. Too much of the brain got damaged, and then you have some difficulties with your speech, or you have some incoordination, and that may or may not resolve. The other part is that it's possible it could wear off over time, and you won't be able to as easily fine tune the situation. With deep brain stimulation, if things progress, then we can increase the stimulation of the device to make up for that progression. But with focus ultrasound, you don't necessarily have that. And so there's pros and cons to the approaches, and it's something you can talk to us about in clinic if you are interested. But it's good to have this approach available, and I think this technique will continue to improve as the years go on.
Is there a certain kind of patient for whom this is ideal or
Yeah,
more recommended?
my opinion is that it's more ideal for patients. Different doctors will have a different opinion. My opinion is that it's more ideal for patients that are older, they're not a candidate for deep brain stimulation, they may have some other medical conditions that make getting a brain surgery more risky. And so this could be a good option for them. I think for most patients, deep brain stimulation has been around for longer. It's easier to fine tune if things progress. As I mentioned, it's more likely to last for longer periods of time. We have less data with focus ultrasound, but not everyone is a candidate for deep brain stimulation for a variety of reasons. So that's when I am thinking more about focus ultrasound. Okay. All right, moving on to stem cells for PD. This you may have heard about, in the news. I think there's a lot of talk about stem cells just in general and stem cells for PD. I want to just point out one thing that in this case for PD, unfortunately, it's symptomatic only. It's not being used as a cure for Parkinson's disease. It is being used to replace the dopamine in the brain, to replace the dopamine neurons, but it's unlikely to prevent the spread of the disease. So there's going to still be progression. The idea is there's dopamine cells are dying, let's replace them. Trials were done in the past with mixed effects. Some benefited, some had no effect. And then some actually had issues with uncontrollable dyskinesias. There was too much dopamine in the brain. And it's being tried again with arguments that there's better quality stem cells and surgical techniques. So I think there's a variety of stem cells out there, but I'm just going to focus on two. The one that is the furthest along is this one by Blue Rock, Bemdaneprocel. And they are beginning their phase 3 trial. The first patient was already treated just last month in this trial. They had a phase 1 study that showed some positive signals. It's showing that the transplanted cells were surviving. It was helping patients have more on time. And so this phase 3 trial is starting. It will also be sham controlled, meaning you'll get a surgery to inject the stem cells, get an injection into your brain, but it's possible your injection may not have the stem cells. So it could be what's called a sham. And that, again, is to help the trial be more statistically accurate and give us a better sense of whether this treatment is really helping or not. And we do hope to have this study at Stanford. Now, with bemdaneprocel, it's being called off the shelf. You're using dopaminergic neurons that are derived from a general human line. This other stem cell approach that is being used uses your own skin cells and converts them to new dopamine neurons using a variety of molecules, and then can implant them. So the potential advantage here is because it's your own cells, your body will be less likely to reject them, and your body will think of them as its own cells, which could reduce side effects. And so that is currently in an early study, phase 1/2A, with the third group of patients now receiving the treatment. Then some updates on deep brain stimulation. So deep brain stimulation I touched on it a little bit before, but it's a surgical procedure where we implant electrodes into the brain. It's connected to a small pacemaker sitting in your chest, and it's stimulating certain areas of the brain to reduce motor symptoms. So help reduce slowed movements, stiffness, and tremor. And it's been around for a long time. It's a very established approach. And there are some new updates. So one of them is this adaptive deep brain stimulation has received FDA approval. And so the idea here is that prior deep brain stimulation just gives one continuous stimulation. But with adaptive deep brain stimulation, it's reading signals from the brain, and it can potentially use that information to optimize the stimulation that we're giving in real time and adjust it on a moment-to-moment basis to try and help symptoms optimally throughout the day. It's very early stages for this technology, but that's the overall hope of this approach. And so in early 2025, it was approved. And then Dr. Bronte Stewart is working on expanding the role of deep brain stimulation and where in the brain it could be stimulating. So we know that in Parkinson's disease, there can be impairment of cognition, of thinking, of memory, and that seems to be related to a certain part of the brain, this NBM, dying. And so she is starting a study to stimulate that part of the brain to potentially help with cognition. And so information about that trial is here. This is a very early study, and something that she's exploring. All right, so to summarize, I talked about disease-modifying therapies, all the approaches that are in progress right now with the alpha-synuclein reduction. Prasinezumab, I would say, is the furthest along. The phase 3, or one of the farthest along. The phase 3 trial should be starting soon. Ambroxol is also far along. That one is in phase 3 in the UK. And then in terms of symptomatic therapies, these approaches, Tavapadon, these are all improving our toolkit for helping patients' symptoms in PD. And Tavapadon, we'll hear likely next year whether that gets approved. The subcutaneous infusions for smooth control in theory, throughout the day, that has been approved. And then focus ultrasound is approved with some new targets and things being evaluated. Stem cells are entering phase 3. And we touched on some of the advances in deep brain stimulation. So I will open it up to any questions. Thanks for listening. And if
Great.
there's anything
Thanks
we can
very
talk.
much, as always, Dr. Chattree. Okay, we had a couple questions. Could you go back to the CPL 36
Sure,
slide?
sure.
Somebody they said, could you review the information again? So
Sure.
my note was that it's for dyskinesia, of course, and you think it's probably going to phase 3, that phase
I
2
think it's
was
probably going to phase 3 because the company released this very excited statement. They were like, we feel very confident that it's working. I want to say it was something like that. It was a very excited statement that they released. And so, yeah, just to review, dyskinesias are something that develop later in Parkinson's disease as you go up on your dose of levodopa or as the disease progresses. levodopa is helping with certain things, but it can also cause these involuntary movements. And so this drug is acting on a different enzyme, a different receptor than levodopa, but still in the same brain area to try and reduce the dyskinesia signaling in that brain area. And the phase 2 studies were positive. It showed a clinically meaningful and a statistically significant reduction in dyskinesia. So I think it's likely that it will move to phase 3. The
Okay.
main side effect was mild to moderate drowsiness.
Okay. And can you take a step back for just a minute?
Yeah, yeah,
You mentioned two causes, possible causes of dyskinesia. I think, at least I think you said one
yeah.
is high use, high dosage over many years of levodopa, carbidopa, levodopa, and then the other one was just disease duration, disease progression.
Yeah, what I mean by that is the way that dyskinesias are potentially caused. So one, you have to be on levodopa for it. Um,
Okay.
but it's not necessarily like how long you've been on levodopa. Because that's what we used to think. But then there were some studies showing that even if you delay taking levodopa, you may still get dyskinesias at the same time. And really, what contributes to dyskinesia is how does your brain buffer the dopamine that you're taking in? So, as the disease progresses, the ability to buffer the levodopa gets reduced. And so, more of the L-dopa is out there, able to act on things and maybe, causing these abnormal movements. And so, and the more you take, the higher dose you're on, again, it becomes harder to buffer all of that medication.
Okay. All
Yeah.
right. And it used to be, I don't know, maybe when I joined the community back 20 years ago, we were kind of, I felt like on the hairy edge of still saying hold back on starting levodopa because of dyskinesias. We no longer say that, right?
We no longer say that. The official recommendation for most, I think all the major organizations are it's the best treatment for Parkinson's disease, carbidopa, levodopa. There's no clear evidence or indication to delay if you think it will improve the patient's quality of life.
Okay, and this is true whether high doses of levodopa cause dyskinesia or not. This is still the
Yeah,
recommendation.
yeah, because it's now thought to be less that the drug is making changes. It's more that the
The
brain
brain.
is undergoing some changes, and then its ability to buffer that drug is not as robust.
Okay, all right, great. Could you go to the slide? I think it's the next slide on Vilev and
Yes,
Onapgo. Yeah.
yes.
So, I forgot to ask you, who are the ideal patients for these
Mhm,
medications,
mhm.
these approaches?
So when I'm thinking about these medications, I would be thinking about a patient who is on something, either carbidopa, levodopa, or something similar. They are getting some benefit from the medications, but they're getting some side effects. It's causing dyskinesias, or it maybe is causing too much drowsiness. And they're also having off periods, so they're having to take the medication very frequently. And so we call this motor fluctuations, that they're having a lot of fluctuations throughout the day because they can't quite get a stable amount of control throughout the day. And sometimes and in some cases they may be going too high or they may be going too low. And so that's when we start to think about like interventions. So interventional approaches. So that could be the subcutaneous infusion or deep brain stimulation or focus ultrasound. Once someone has motor fluctuations and dyskinesias, that's when we start to think about that. And
Okay.
so for patients that don't want to do deep brain stimulation or they don't meet criteria for deep brain stimulation, this is a good approach to try.
Okay. And how would you compare the subcutaneous infusions with focused ultrasound?
With focus ultrasound, so
Sorry to try to nail you
yeah,
down.
sure, sure. The advantage to trying this first is this is not a permanent thing. You try it, you can try this infusion. If you don't like it, you can stop it and go back to medications. The thing about focus ultrasound is that it's a permanent thing. And I think there's still stuff that needs to be worked out. Like, can you do both sides of the brain without causing too many side effects with focused ultrasound? People feel more comfortable just doing one side of the brain. And then if you're doing one side, you're not really getting full symptom control. Yeah.
Yeah. We've heard in our support groups uh, some some positive things about the subcutaneous infusions, but we've also heard a lot about the hassle of changing the infusion site every day and
Mhm.
infection at the infusion site.
Yes, that is definitely a challenge with this. Uh,
Mm-hmm.
yeah,
Yeah.
because you have to have this pump, you have to, clean it and manage it, that does become a hassle. And so
Yeah.
some patients do not like that, understandable.
Right.
Yeah,
Okay. I don't see any more questions on any of these studies or treatments, but we do have other questions. So I'll
sure, I can see
launch in.
those. Yeah, I
Yeah,
can look at
somebody
them.
says, what about cannabis use along with levodopa for Parkinson's disease in early stages with brain fogginess?
hmm I would say with cannabis, it's one of those things that hasn't been formally studied, so it's always hard to make specific comments. Of course, many of my patients have used cannabis or tried cannabis, and again, it's mixed results. Some people say, yeah, it does make me feel better. Some people say, I can't tolerate it at all. It makes me, too drowsy or even more confused, leads to some confusion. So it's sort of hit or miss, with cannabis. I think everyone's different. And it has not been formally studied to say like, yes, it will help with brain fogginess. I will say it's possible it could even, in some patients, it could worsen brain fogginess. It's tough to say.
Mm,
Yeah.
right. Okay, somebody asked about DAT scan. Could you say a little bit about DAT scan? And the person's particular question is, can you be on levodopa to when you're having
Yeah.
a DAT scan?
Yeah. So DAT scan is a study that is essentially looking at the health of your dopamine neurons in the brain. And it does this, it's a CT PET scan. There's a tracer that goes in and shows you certain receptors or molecules that are a marker for the health of your dopamine cells. And in Parkinson's disease, those dopamine cells are low, and so on the DAT scan, it will show a lower signal. And it's a pretty good test. I think it has good accuracy. It's best if you do it at a center that does them a lot, has the quantitative version of the DAT scan, because it does take some expertise to do it properly. And can you be on levodopa? Yes, you can. You can be on levodopa. So there are certain medications that you cannot be on when you get the DAT scan because it interferes with the scan. So those are typically certain psychiatric medications are the most common. So you always want to check on that, whether those are compatible with the scan. But levodopa is actually, maybe counterintuitively, it doesn't affect the scan.
Hmm. And could you talk a little bit about how the DAT scan is used in terms of diagnosing Parkinson's disease or Parkinsonism?
Yeah. So let me start with the definition of Parkinsonism. So, Parkinsonism is something we observe clinically in the patient when we're doing our examination and talking with you and getting your history. Are we getting a sense of slowed movements, stiffness, and or a certain type of tremor, rest tremor? And Parkinsonism can be caused by a variety of things. The most common cause is Parkinson's disease. but there are some other conditions that can mimic Parkinson's disease. Um, these can be called atypical Parkinsonian disorders. They look like Parkinson's disease initially, but then they develop some other issues and they're not as responsive to the medications of Parkinson's disease. And then in other cases, sometimes Parkinsonism is caused by medications or some vascular changes in the brain, like stroke-like related things, or even infections in the past had caused Parkinsonism. And so when we are looking at the DAT scan, we are really just looking at Parkinsonism secondary to dopamine cell loss. We cannot say for sure it's due to Parkinson's disease. It could be some of these other mimics that have led to that dopamine cell loss. So we put it into the larger clinical context, okay, we're seeing dopamine cell loss, and there are certain things on history you're telling us and things that we're seeing on exam. So putting that all together, this sounds like Parkinson's disease. But it could be we get the DAT scan and we say, well, yes, there's dopamine cell loss, but there are certain features of your exam and things maybe you're telling us on history. We don't think it's Parkinson's disease, but a mimic of Parkinson's disease, something like Parkinson's disease.
Okay, I don't see any more questions here, but one question that often comes up is the skin biopsy. Maybe you could
Mhm.
talk a little bit about that.
Yeah, so we have two new tools for helping make the diagnosis of Parkinson's disease. And one is the skin biopsy. So that is looking for this atypical abnormal alpha-synuclein that I had talked about, and it's looking to see if it's built up in the skin. So it's three small biopsies, one near the neck, two near the leg, and then it gets sent to the lab and they're evaluating it for that. And I think the company certainly says there's good accuracy with this testing in terms of making the diagnosis of Parkinson's disease. My own feeling is I think maybe it's early stages. We should be continuing to observe and get a sense of what is the true accuracy of this. So we should just, when you get this result, just, keep that in mind. It's still an early test. It's a new test. But yes, it's designed to, unlike the DAT scan, which just tells you about Parkinsonism, this one is designed to say, do you have Parkinson's disease, or, well, it can't separate from multiple systems atrophy, which is also another, it can't separate that well from multiple systems atrophy, which is another alpha-synuclein condition. So it helps make the diagnosis of an alpha-synuclein condition, which is Parkinson's disease, dementia with Lewy bodies, or multiple systems atrophy. And then the other test now is a lumbar puncture, where we get the spinal fluid. And again, we're looking for that alpha-synuclein, a misfolded alpha-synuclein, and is designed to diagnose Parkinson's disease. And I do think the company is showing signs that it can separate it from multiple systems atrophy, but I don't think it can separate it from dementia it cannot separate it from dementia with Lewy bodies.
Right. Okay. All right. I don't see any more questions. So thank you, Dr. Chattree. It
Sure,
was a
no
wonderful
problem.
talk, very informative as always,
No
and we'll
problem.
see you next year.
Yeah, see you everyone.
Okay,
Bye.
great. Bye-bye. Bye, everyone. We have another speaker in our next month, November. See what November 12th. That's a Wednesday. Is somebody talking about fall prevention in Parkinson's disease. So we'll see you then. Bye-bye.